So we just heard the talk about the problem of opioids in adults. But do we have different risk factors or concerns in the pediatric population? Are kids at different risk? The purpose of this talk is to explore the factors that are characteristic of adolescents. So in pediatrics, the lifetime use of medical use of prescription opioids peaked in 1989 and then again in 2002. From 2002 to 2013, use of opioids was stable. And then it started declining from 2013 to 2015. The non-medical use of prescription opioid is thankfully less than that of medical use of prescription opioid. But non-medical use correlates with medical use of prescription opioids with an R of 0.552, which means that there is a strong correlation between being prescribed prescription opioids and then using it without a medical indication. When we look at gender and race differences, we see some differences in adolescents. The lifetime use of medical prescription of opioids is more common in female adolescents. There is no difference in the non-medical use of prescription opioids. The correlation between medical use of prescription opioids and non-medical use of prescription opioids is stronger in adolescent males. In the medical use and the non-medical use of prescription opioids is more common in white adolescents than in black adolescents. The exposure to medical use of prescription opioids has varied over the past 40 years, somewhere between 8 to 14%. In those who have both medical use as well as non-medical use of prescription opioids, the ones that have non-medical use most often started with medical use of prescription opioids. So about 2 to 5% of adolescents that had opioids prescribed will continue then with non-medical use of prescription opioids. The medical use of opioids in high school increases by 33% the risk of developing opioid misuse later in life. Data from 2018 showed that somewhere between 0.6 to 0.8% of eighth graders have misused prescription opioids, Vicodin or OxyContin. And this number increases when we get to the seniors in high school, to 1.7 to 2.3%. 7 out of 10 teens that use non-prescription opioids will combine it with other substance. 59% with marijuana, 52% with alcohol, 11% with cocaine, 10% with tranquilizers, and 9.5% with amphetamines. There are certain factors in adolescence that may predispose for non-medical opioid use later in adulthood, and that includes chronic pain in adolescence, history of trauma and other substance abuse. But what is unclear is if those patients that had a chronic pain were prescribed opioids or not. We also know that when we prescribe opioids after surgery, that also increases the risk of continue taking non-medical prescription opioids afterwards. This study, published in Pediatrics in 2018, showed that 4.8% of patients, adolescent patients, who had surgery and were prescribed opioids will persist using opioids 90 to 180 days after surgery. They found that people that had cholecystectomy and a colectomy were the ones at higher risk. Other risk factors, again, include being female, older age within the adolescent range, previous substance disorder, chronic pain, as we reported earlier, and when they filled the opioid prescription prior to the surgery. So why are opioids worse in adolescents? What we need to understand is that the brain is still developing in adolescence. So the immaturity of the adolescent brain makes it more vulnerable to the effects of abuse of alcohol and other drugs. And that produces long-term behavioral and cognitive dysfunction. The we have heard in the previous talk that opioids have an inflammatory response, and that causes neuroinflammation and neuronal damage. When the brain is still developing, as it happened in adolescence, that increases the risk of addiction later. We also need to know that with the lack of full developed brain, comes that the adolescents have less self-control, which also predisposes them to more risky behavior. Another factor that is unrelated to the brain development is that many times adolescents may have opioids in the house from the parents and the grandparents. And if we put this in association with a brain that is willing to take risk, then the risk of addiction increases more. So in conclusion, we learned that chronic pain is a big risk factor to the misuse of opioids. Therefore, as a primary care physician, or even if you're a subspecialty, we need to be sure that we are really treating chronic pain and not ignoring it. I think that part of the key message here is pain is real. Therefore, we can't dismiss patients with chronic pain. Now, on the other hand, opioids are not a solution. We know that exposing the patients to opioids increases the risk of addiction. So, going back to a lot of what we are going to talk in this program, using an interdisciplinary biobehavioral approach is the way to treat those patients. And I think that for primary care physicians, the key issue is that opioids should be your last resort. There are a lot of other medications that can be used to modulate pain without going into opioids, as well as using physical therapy, cognitive behavioral therapy, and other modalities that we will discuss throughout this course. Very important is also the exposure of opioids after surgery. What we saw in this talk and what we learned from studies published in the literature is that about 5 to 6% of adolescents that receive opioids during or after surgery will then continue using opioids or misusing opioids afterwards. Therefore, we need to look at other ways of modulating pain or controlling pain after surgery, and that may include some regional blocks, non-opioid medications that help modulate pain, as well as going back to the biobehavioral approach. Knowing that adolescents tend to have more risky behaviors, and many times they don't feel that prescribed opioid medications are a problem, when families have opioid medications at home, they need to be discarded if they're not being used anymore, or they should be logged to avoid the temptation of trying medications by the teenagers. Thank you.